Um, as Gazpai mentioned, the primary purpose of this presentation is to really introduce the audience to EUS. And obviously there are people here who already are doing ultrasonography and EUS and others who may be getting started or have an interest in it. So I will try and keep this basic. And the three ways in which I broke this down was the basics of ultrasonography itself, endoscopic ultrasound and echoendoscopes, and then just a brief overview of the anatomy that we often encounter primarily in upper EUS and endoscopic ultrasound. Because all three go hand in hand for us to be able to then do appropriate high quality EUS. And I think if we start with the very basics, a lot of us know some principles, but oftentimes come into it somewhat uncertain about how things work. But audible sound obviously is in the range of lower frequencies, 20 to 20,000 hertz, megahertz, for us to be able to, so 20,000 hertz for us to be able to actually hear. Ultrasound, the word ultra implies that these are much higher frequency sounds. And these basically are the sound waves which are used via an generated via an electric signal through crystals. And these crystals make this sound wave occur. The vibration of the crystals leads to the sound waves to try to be transmitted, hit the tissue of interest, and then return. And when these sound waves return, that signal is converted back into an electrical signal, and that's how we'll generate the image. So the principles of ultrasound, which most people may be familiar with, of course, are that there's the incident wave, which attaches to or which goes and bounces off some waves will penetrate through, and others will come back, and then these are what generate the signal. For the highest quality reflection of the wave, it has to be a 90-degree angle. So whatever goes forward comes right back at you. Some of it will penetrate through. If the signal is coming at an angle, then what we get is refracted waves, and those waves can give you artifactual signals. So one of the principles with ultrasound is obviously having your probe as close to the object as possible and right on it, as opposed to trying to visualize it from an angle. And sometimes in endoscopy, obviously our scope can only reach a certain point, a certain angle, and we are only able to get a limited view. But understanding that concept and not, falsely falling for the trap of a limited view being a lesion when it's not. For instance, sludge in the gallbladder can be not there, and we can think that it is because of the acoustic sort of reverberations that we get. So the second concept in this is scatter. So a small amount of the energy that is reaching an object actually returns back. A lot of it gets transmitted. It's like X-rays, either gets transmitted or bounces off and goes in different directions. And each individual component within a tissue organ will have different amounts of scatter. So if you think about the pancreas or the peripancreatic tissue, the fat around it will have different amount of scatter as opposed to the solid parenchymal tissue. And then if there's a mass in the pancreas, that'll have a different amount of scatter. And it's all these little things that come together to give us the different densities and echotextures that result in our final tissue. So that's how we end up with the echotexture based on the different amounts of scatter. So if you take this example of a pancreatic mass, you can see that the peripancreatic fat, which is to the left of the screen, is brighter. And so the scatter pattern is such that it's going to be different. So fat will show up bright. And we term this in terms of echogenicity as hyperechoic. A pancreatic mass will be typically very discrete, clear borders, and it'll be much darker And so that is going to be hypoechoic. Blood vessels and cysts will allow the ultrasound signal to go right through them, and they will be completely black. And so this blood vessel here has absolutely no shadow, no echo, and it's basically going to be anechoic. So these are the different types of scatter that lead to the different types of imaging properties on ultrasound. So a bit back to the basics. The way this works is the ultrasound wave can be displayed simply as a waveform over time, but it's of no use to us. You know, looking at waves doesn't help us. We want to be able to visualize the object. So the wave is converted into the signal in terms of brightness, and hence the term B mode. So the most common, the biggest button that you will see on a console is the big round circle called B mode. And that's the brightness mode. B stands for brightness. And this is the conversion of the ultrasound waves into a bright signal that we can then visualize. So this is the default setting on any EUS machine that we will be using to look at our signal. And as the probe basically goes over a tissue, if this is the path of the probe, this way you can see that there'll be waves that will be generated, and those waves are converted into the B mode scan line. The brightness of any image can be altered to make it brighter or darker to optimize the image quality. And so this brings us to the second component of understanding this, that there's the brightness can be controlled overall of the entire screen using the, say, big dial on this big console. But then you also have a mechanism by which you can actually fine adjust the brightness at different lengths of distance from the probe. And so it'll either be mechanical keys, which can be used to adjust the brightness as you go left or right, versus it can also be electronically done on the smaller EU ME2 machine. But the whole concept is that as the distance from the probe increases, you can have loss of brightness, and you can adjust for that accordingly. So along with the brightness, the other concept to understand in endoscopic ultrasonography is the concept of frequency and resolution. And I think the concept here to understand that if a wave is going through a tissue and there are 2 points across in the same plane, so imagine that you have the mucosa and submucosa. The idea is that the higher the frequency, the better the image perception will be, because those smaller waves will go through at a higher frequency and bounce back and give a much clearer image than, say, for instance, here, versus the wider waves, which will only go at a much smaller frequency. So the concept that needs to be understood is that if you increase your frequency of the wave, you're basically increasing the ability to discern things that are close to the probe at a much higher resolution. This comes at the cost of your depth of penetration. So the bigger scopes, the linear or the radial scope, will generally be in the 5 to 10 megahertz range. And these will give you axial resolution of 0.4 to 0.8 millimeters. And can give you depth up to 4 to 8 centimeters. But for the highest quality resolution, say of submucosal lesions, intraluminal lesions in the wall, gist or a lipoma, those lesions will probably be best visualized with a higher frequency probe, and these typically end up being mini probes. A standard EUS scope will certainly give you very good quality images, say for a gist, but to get the most clean image, it would be a separate probe that is a 20 megahertz probe, which is similar to a 10 French or 8 French catheter that has to go through the scope channel. So those are some of the other concepts. As far as lateral resolution is concerned, that is, side by side. So you have a mass and you have a normal tissue next to it, like the image before. there it's more a case of the width of the signal. So that's going to be standardized on the EUS scope because you have the probe, which has a standard size, and the signal gets transmitted. And then functions related to the transducer itself, the size, shape, frequency, etc. So this is more of a fixed thing for us, whereas the frequency in terms of the frequency can be altered even on the bigger scopes, but to get the highest resolution, go with the mini probe. The next component I think I would mention would be the concept of Doppler shift and Doppler flow. So ultrasound, when it comes at 90 degrees, it gets reflected back right up at us, and that may not show us movement. But if you move the transducer at an angle, then you see you're able to actually accommodate or visualize the flow because the moving object will transmit at a different angle. And so that concept allows us to visualize flow within an object such as a blood vessel. So those are the four basic concepts we need to understand: how ultrasound works. I didn't go too much into the details of artifacts and attenuation. All those concepts are available to understand in deeper detail, but the principles need to be understood about how ultrasound signals are generated, what the purpose of the gain and the brightness is, the frequency and what the relevance of that is, and then Doppler flow. And some of these things I'll overlap. So you can have different types of machines nowadays. Obviously, you have the big EUS consoles, but Olympus has a smaller unit that can be part of your endoscopy cart and has a sort of keyboard panel which allows you to adjust various components, and actually gives a very decent quality image. So this is the EU ME2 keyboard, and there are a lot of buttons here. A lot of them we don't actually use, but it's important to get to know these and work with the local representative to understand what the principles are, or working with your colleagues in radiology to understand this. So in terms of the main keyboard, of course, when you first start out, your image is often, it will be frozen. So there is a simple button to freeze and unfreeze your image, which we need to know about. The other sort of big ones to point out, the gain for the brightness is there. So that's your main sort of brightness. And then the depth, how far in and out your image will be zooming in and out. That allows you to determine how deep your image is based on the size of your lesion. This is the gain. It can be defaulted at various settings based on the machine, and then you can adjust in order to make your signal brighter or darker. Frequency, the linear and the echo endoscopes, and I'll come to the scopes in a minute, defaults at 7.5 megahertz. There is what's called a therapeutic channel EUS scope, which is a 10 millimeter channel similar to ERCP. And then there's the model that Olympus uses, a P scope. People call it a pediatric, which is not technically a pediatric scope, but that has a 7 French channel. And based on the scope you have, the quality of image may vary. In my experience, the P scope seems to give a better signal at 5 megahertz, but the current standard adult EUS scope gives a better image at 7.5 megahertz. But these are all things that you can adjust. This is from a textbook, and this is just showing the concept of optimizing your image. So here we have too bright in A, we have too bright an image. So the gain is too high. You can lower the gain, but then your resolution isn't as clear. So if you just go to a higher frequency, it becomes slightly better, but then with the fine tuning of the frequency using the STC, sorry, the gain using the STC component, then you can actually get a much neater, cleaner image. You can see the acidic fluid, much cleaner contrast compared to the solid tissue here. Now in reality, a lot of people will typically not mess with the STC adjustment and play more with the gain as well as the frequency. But some of it is because we just don't know how to do it, and we don't know that those tools are there for us to use. Um, then you have the sort of the ability to alter your image, whether if this is a radial scope, you can have full image, half image, depending on what you're looking at. And then the component of flow, which is very important to identify a vessel. Sometimes we think we're looking at a cyst and you put the Doppler on, or you're looking at the bile duct and you put the Doppler on, it turns out it's a portal vein or a hepatic artery. So the flow button is important, and they have different types of flow, which we won't get into, but you can have, red and blue depending on flow towards you or away from you. And then you can have very fine flow, which picks up the slightest movement. Of course, we are using the scope and moving, so you can get artifact by moving the scope. The point is that we need to be aware of it and be able to use it to identify things. One thing I will say is, which is helpful, is the power pulse wave button, because this allows you to not only just look at the flow, but actually look at the waveform. So sometimes you're thinking, well, I think this is the portal vein, or this is the splenic vein. Actually put the flow on and you look at the power wave, and you can actually identify it as being an arterial waveform, which will be very spiked, of course, as opposed to a venous waveform, which will be more flat. So the pulse wave, in addition to the flow, will help us identify arteries versus veins. So I think in terms of ultrasound imaging and functions on the scope and the keyboard, those are the main concepts to understand. That these are the buttons, these we should be very familiar with, and we need to get to know. The second component, of course, is our equipment that we are using to visualize our image and knowing our scopes. So the main thing here is that the EUS scopes are not similar to the ERCP scope. They have some shared properties, but they're actually, definitely there's a learning curve to handling them and understanding them, and the principles of handling them are different. If you look at these scopes side by side, this is the Olympus upper endoscope, this is the radial, and this is the linear head-on and sideways. And you can see the tip right away. The linear has a curved tip. The radial has a blunt, round tip similar to the upper, but the differences show up when you start maneuvering the scope. So when you flex the big wheel on the upper scope, which is 9.8 millimeter, you can see that the tip that gets flexed is much shorter compared to the radial or the linear. And so once we're going through, say, the oropharynx or the G junction or the duodenal sweep, those are the areas where we have to be careful with these slightly more larger scopes and the rigid tips. Secondly, the upper scope looks straight ahead, whereas the radial looks slightly at an angle, and then the linear will certainly look at an oblique angle as opposed to these two. Whereas the ERCP scopes looks more at a 90-degree angle, this is less than 90 degrees. So it's not exactly the same as a side viewing ERCP scope. The second difference is to know between different companies. So on the left, you have the linear scope, the therapeutic in quotes, 10 French linear scope from Pentax, and this is the one on Olympus. And the whole point is that the scanning area is going to be different. And then the roundness you can appreciate on this scope, whereas here the tip tends to be a bit more sort of straight and sharp. So one has to be careful with that. And simply just going to the company's website, you can figure out the various sort of scope configurations, outer diameter, inner diameter, working channel, etc., for understanding the different types of scopes. Also, you can get the frequency and the compatibility with the different equipment that they produce. The other components to understand are that unlike ERCP, endoscopic ultrasound really is the opposite, where in ERCP we say get to the papilla, stabilize yourself, small movements, you have to be very, very controlled. Of course, you have to be controlled in EUS too, but the key concept here is that you actually have to be more mobile and fluid in terms of diagnostic EUS. So your left hand has to do a lot of moving uh, to allow the scope to freely move. You can get 360 degrees with the scope without having to necessarily too much with your right hand, with the left hand doing most of the work and your right hand just supporting the scope inside the patient's mouth. So that concept, I just want to play this again. You can see that with the movement of the left hand, the probe is doing a lot of movement in terms of scanning the tissue. Okay, the other thing is the flip side of it is that if you don't do that and you get very tense on your right hand and you're doing these extreme movements on the left hand, nothing's really going to happen. Your left hand's doing a lot of work, but you're so tense with your right hand that your ability to scan that tissue that you want to visualize gets very compromised. So fluidity in your movement and just going, using it as straight as possible, working loosely actually helps in diagnostic EUS. The other components to understand, similar to ERCP, would be the big wheel and small wheel. As you flex the big wheel, that's, I use the term big wheel up, and the opposite of that would be big wheel down or big wheel away from you. You can extend it. So there's a lot of range of motion you can see there with the linear scopes, which allows you to not only visualize and sort of maneuver your scope, but in terms of sampling, that allows you to change your angle significantly. And the same goes with the lateral movement. Sometimes you know that you're seeing part of a lesion, but you're just not getting a full view. And all sometimes you have to do is move your probes, the lateral small wheels left and right, and that'll give you the ability to get your lesion in target, both for visualization and for sampling. So those are sort of some basic concepts. In terms of sampling, you have an elevator which allows you to maneuver your needle up and down, similar to ERCP. So you can see the needle coming out and then you can maneuver it. And then the other thing to understand is that you can use your big wheel, you can lock it in plane, and then you can use your elevator for finer movements. So you have the ability to lock your wheel similar to any other scope, which allows you to stabilize, whether it's for diagnostic or therapeutic purposes. I didn't go too much into this, but I think it's important for everybody to know in terms, and I'm sure this will be covered in a different sort of lecture too. In terms of the needle, there's an adjustment for the shaft. So the lower adjustment on the needle allows you to determine how far out the needle sheath comes out of the scope. And then you have the upper handle, which allows you to move the needle in and out. So you can adjust your needle, the distance that it's coming out of the scope, as well as then how much needle comes out. But those are topics that will be covered elsewhere. So the third component of this talk, which I think is probably sometimes underrepresented early on in education of EUS, because there's a sort of concept of the more you see, the more you do, the more you understand it. And I think as I have evolved my own learning over the course of time, I think that is true, though I will say that understanding the anatomy or trying to understand the anatomy somewhat going into it is generally a much more educational experience, in my experience, than going in completely blind and trying to learn images and just memorizing images. And I think it has to go hand in hand. Some of it just has to be done. You have to do like 50, 100 EUSs to try and understand how things work. But then at the same time, if one is trying to understand normal anatomy, then it helps. But it's challenging for many reasons. We're not used to looking at ultrasound images, so interpretation can be challenging for us. The scope movement allows for the image to be visualized from different planes, and things can change very quickly in ultrasound with very little movement of the scope. And that can be very sort of challenging for us as physicians entering this field to fully understand what's going on. And then things that we don't anticipate may play a role. Obesity, sort of abdominal fat can have a role. Hiatal hernias, getting the scope stuck in there can be a challenge. There can be variations in the anatomy, the duodenum or the stomach, or the G junction. All of those little variations can make visualization, what should be straightforward, difficult. I do think that cross-sectional imaging may not necessarily help all the way, but it certainly does help in understanding what to target for. I think there should be a sort of ongoing self-assessment where you say, there's no heroism in trying to going in blind and saying, let me just find the lesion. If it's the pancreatic head, I'll find it. I think one should understand that if it's in the pancreatic head, I should know where to look for it. But at the same time, we owe it to our patients that if there's a CT scan, we should review it, because that can help us identify lesions. So having said that, I think the imaging studies do help. In terms of areas evaluated by EUS, in the upper GI tract, of course, intraluminal can be wherever the scope can get to, so esophagus, stomach, duodenum. Lower GI tract, of course, rectum and distal colon. And the extraluminal structures, which is really what primarily we use it for most commonly, would be the pancreas, the biliary tree, liver, lymph nodes, other organs, and vasculature. And I guess the two ways to look at how to interpret images would be organ-based. So can I visualize the entire pancreas? Do I know how to visualize the head, body, tail? And then the whole station-based approach, which I won't go into too much today because I'm sure that'll be covered later. But the idea is that one has to be, we're not fixating on stations, but more importantly on being able to identify our organs, our areas of interest or structures. So if I'm doing a pancreatic mass evaluation, I should be able to evaluate the entire pancreas, whether it's from the stomach alone or stomach and duodenum, and so forth. So in terms of the luminal layers, this is some basics that will be covered over and over in other talks, but you have the 5 layers. The dark layer, the first bright layer is going to be the mucosal interface, and right below it, the first dark layer will be the muscularis mucosa. The brighter layer will be the submucosa, and then the 4th layer is muscularis propria. And depending on where we are, we'll see the 5th layer, which is the serosa. So this is, these are the 5 layers that we should all be familiar with of the GI tract, that we primarily will looking at if we're trying to stage tumors in the wall or for epithelial, submucosal lesions. Now, when it comes to the mediastinum, of course, there's a lot there which we don't really tend to focus on. Most commonly, we'll be looking at lymph nodes or esophageal tumors, but some of the ways in which a mediastinal anatomy can be understood, it's similar to, because the diameter of the esophagus is smaller, the scope doesn't have much play inside the esophagus, which allows us to stay, within field and look at our structures. And on the radial, it'll be very similar to CT, and linear the views will be very different. And of course, other than the organs, we can look at vasculature. So these are from some images from a textbook, but I think these illustrate this well. With the radial scope, the round red circle is the esophagus. So our scope is going to be in the esophagus. So if this is a CT scan, you can see the trachea anteriorly, the azygos vein to the right, and the aorta to the left. And with the radial, you can mimic that image. You're in the trachea, you can see, so you can in the esophagus, and you can see these are the esophageal layers. The trachea anteriorly, azygos, and aorta to the left. People teach this differently. The way I was taught, and I actually do this, is because on a CT scan, the spine is like in the middle at 6 o'clock. I adjust my image to bring the spine to 6 o'clock. And so then I'm trying to mimic a cross-sectional view of a CT scan. And as you go further in on the radial, you can then have the bifurcation of the trachea into the two main bronchi. the right and left main bronchi, and then you can see the aorta. The challenge becomes the linear. And I've often thought of how best to teach this and make people understand. And I think from my perspective, this is the best I could figure out a strategy to teach, which was to do some fluoro images as I was in a patient who I was doing an EUS on. You can see that there's some leads. This was an 80-plus-year-old patient. So the additional, we were doing an EUS ERCP anyway, and I figured a few extra images won't be very harmful to the patient, but educationally this will be very valuable. And if you take the image of the scope in the different areas of interest and then correlate it with the CT, then that may allow people to understand this better. So we're in the esophagus. As you can imagine, the patient's laying on their left side typically. So our probe by default goes in and it's facing the left side. And what we're really looking at as we come into the upper esophagus, and this may make more sense to people who are actually doing EUS currently, as opposed to somebody who's never done it. But if you do this over and over, I think it does make sense. And I'll come back to that point later in my sort of talk. But as you look across to the left side, you start seeing structures, and you have to have somebody teach you what those structures are. But over time, it becomes clear. And you can see that you have the aorta on the top, the pulmonary artery on the bottom, and that's what you get. You have aorta more proximally, and then pulmonary artery distally. A couple of things. The green circle here tells you that the orientation of the scope. So wherever this circle is where the proximal end of the probe is. And away from it is the distal end. So you know that you're looking down this way. This is distal, this is towards feet, and this is towards the head. Now, if you really want to understand this, I think because our patient is usually on the left side, this is how it works. Your scope is coming in from the left side through the mouth, coming down. This is feet, this is head, and you're looking down to the left side, and you have your aorta here, and then you have your pulmonary artery. And similarly, as you go in deeper, then you run into the heart, and you're going to have multiple structures. You have left atrium, left ventricle, pulmonary artery, aorta, and these are the CT correlates on a sagittal view. But again, if you turn things around, your patient's laying on their left side. This is a sagittal view now, and you can see as you move your probe around, that the structure that's going to be closest to you will be the left atrium. And deeper to that will be the ventricle. So you get this image, left atrium, left ventricle. More proximal, closer to you will be the pulmonary artery, which is here. And behind that will be the aorta, which is right there. And then that's the aortic valve, right here on the CT. So moving, so radiologically, you can figure out what's going on, especially in the mediastinum. And then just to sort of add another layer of complexity, which we don't need to go through every single image here. At different planes within the mediastinum, you can see multiple structures. Again, if you turn it sideways, as you go down, you can follow the aorta, so you can see the descending aorta, and you can follow that. This was the view we had earlier, left atrium, mitral. Sorry, this is the view. So slightly more proximal, you'll have the left atrium, mitral valve, left ventricle, and then you go in deeper, you get the view that we had in the previous image, left atrium, ventricle, aortic valve, right pulmonary artery. And then as you go further in towards the GE junction, then you get into, as if you can follow it towards the IVC, and you can start seeing liver, and you can actually spin your scope and see right atrium. So having those kind of concepts and correlating with CT and in terms of learning, I think, or education, fluoroscopy really helps. Things do get a bit more sort of not as clear cut in the abdomen, but the things that we oftentimes look at anatomically would be the celiac, the aorta as we come in, the celiac artery SMA. These are anatomical dissection images that I've took from a textbook, which actually tries to correlate this too. And you can see as you come in, you have the aorta, celiac, SMA. There's the pancreas splenic vein. For somebody who's never done EUS, this is just now out of your understanding zone for the most part. The key point here is that the structures are there. The human anatomy won't lie to you. We may not know what we're looking at, but the structures are going to be there. It's understanding how the ultrasound scope works, which is important, which as you start doing EUS, you will understand. Now, once you're across the G juncture in the stomach, most of what you're looking at is actually posterior. You're looking through the back wall of the stomach. So the yellow big arrow indicates our plane of visualization. So your probe is pointing posteriorly. And as you go to the patient's left, or what we term clockwise, you can go towards the spleen. And as you spin towards the left adrenal, and as you keep spinning, you'll go towards the spleen. And when you start going the other way around, when you start going counterclockwise, then you basically go towards the pancreas and you start seeing the pancreas, splenic artery, splenic vein. And this is the CT representation. You're coming from above, you're actually looking down this way, and here you have the splenic artery, splenic vein, and that's your pancreas. I think I have another slide to show this, how this happens in the patient. So with the patients, again, laying on their left side, your scope is in like this. You imagine this is the head, this is the feet. Your scope is like this. This is the patient's right, this is the patient's left. So as you go clockwise this way, you're going towards adrenal, spleen, tail of pancreas. As you go counterclockwise, you go towards neck, head, liver. So when you're doing that, you're basically, this is your stomach, this is the stomach, the probe is looking down here this way, and you're going clockwise this way and counterclockwise this way. And this will then lead to this kind of a image. The probe is here. Here it says actually H, which is towards the head, proximally, and tail. So that's how your initial views of the pancreas will be in the stomach. Now, if you keep going counterclockwise, you'll go, as I said, you'll go towards the liver, towards the head, neck of the pancreas, and you'll start seeing the pancreas duct going down towards the head. And if you advance the scope further in, so you've gone from G junction, proximal body, toward distal body, antrum area, you can actually follow the pancreatic ducts, not in everybody, but in a lot of the patients, all the way down to the duodenum, just from the stomach, and you can see the distal bile duct. And if you think about it, you're basically following the P like this, pushing it, and you deeper down, and you're following it towards the papilla from the stomach. Here you will see the confluence of the splenic vein, the SMV, the portal vein, which is here. So you're basically coming across like this in your view. So these vessels can get confusing, but repetition and understanding where you are will help you understand how you get to various organs and vessels. So that's, you can do this either withdrawing from the antrum and looking for these structures, or from sometimes pushing in from the body in. Now, when you go from stomach into duodenum, what you're actually doing is, if you look at the fluoroscopic position, this is like your long position in the bulb when we are treating peptic ulcers, or we're in the ERCP scope, or before we reduce, you're actually going a big loop in the stomach pointing upwards. So your probe, if you look at this, if this is your duodenum, your probe is actually here, and it's going to point up. And I zoom in here. So you're in the bulb, you're looking up this way, and you can see on CT, the closest structure to you is the bile duct. So depending on how your probe lines up, this is obviously shown for ideal view, but when you get your probe in the right position, then the structure that's most proximal to the probe would be your bile duct, and behind it will be the portal vein. And from there, then you can basically go, ideally your goal is to follow the extrahepatic bile duct all the way from the hilum down to the major papilla. So as you go counterclockwise with your probe, you go all the way to the hilum, And as you go clockwise, you can go all the way to the papilla, and you can evaluate the entire extrahepatic biliary tree. And as shown on the image on the left, as you come clockwise towards the papilla, you can actually see the distal pancreatic duct, and you can see them come into the major papilla, and you can see the duodenal wall and duodenal lumen to the left of the screen. But there you can do a lot of things in the bulb. You can look at the pancreatic duct, the confluence, the portal vein as it comes down into the SM and joins the SMV and the splenic vein and the tail of the pancreas going off this way. You can see the hepatic artery, gallbladder, kidney, etc. The orientations change compared to the stomach, but the main thing is to understand that they do change. This is perhaps one of the easiest sort of final things to understand because it's very similar to ERCP, that once you're in the duodenum second portion, you're lined up similar to an ERCP. So your probe is looking this way towards the head of the pancreas. And if you look at the CT, again, you're pointing this way. And what we know from ERCP is that the pancreatic duct is more to the left, which is the screen right, and the bile duct is more to the right, which is screen left. So when you go more clockwise, i.e. towards the anterior of the patient, you'll get the pancreatic duct. And as you go counterclockwise, more towards the posterior of the patient. So the probe going that way towards the back would be bile duct, going this way towards the front would be pancreatic duct. And here you can see the pancreatic duct and the bile duct. And this is fluid in the duodenal lumen because the papilla is right there. The papilla is going to be right here. And this is the downstream duodenum. And on this patient, as you go more counterclockwise, you're going more posteriorly, you can then follow the bile duct up. Similarly, you can follow the pancreatic duct. Incidentally, this is a CT scan of a patient with a stone in the distal bile duct. But the ultrasound is not that patient's. So anyway, so you can follow the bile duct up. Now, we're not talking about therapeutics, but when we do rendezvous, this is where we puncture the bile duct distally and then advance our wire here. So I guess in terms of EUS, the keys are anatomy. Repetition is key. Understanding improves with case volume. But going back to the normal anatomy, what to expect, and just revising it, you know, for trainees early, over and over before every sort of day, or even every case. Early in my training, there was a book chapter on normal linear anatomy, one of the textbooks that I was literally reading 2-3 times a day because I was just trying to understand these views. But it finally sort of clicks, and it, as you do more and more, it becomes easier. I think it's really important if you have cross-sectional imaging to review it beforehand. CT for me is the easiest to understand. MRI is helpful for pancreatic duct and bile duct, and then PET scans obviously for lesions that you're targeting. Understanding that it's a dynamic procedure and you have to move around and recognize the different structures. This is in order. If you're lost, identify your key structures. Figure out what arteries you recognize: aorta, celiac, splenic vein, splenic artery, and figuring it out. You can use your Doppler flow, etc. And then utilizing online videos, EUS books, courses. I think I should add Twitter to this. Dr. Nadeem Tahami did a very nice Twitter sort of basic introductions to basics of EUS last Sunday. So there are a lot of resources online. There is a very good DVD. I think somebody mentioned this on the PSC forum last night by the guys in St. Thomas's providers through the ASC, which actually his description of the normal EUS is very, very good. And so there are a lot of resources available. And from my perspective, a lot of my learning actually obviously was with mentorship from my seniors, but then interestingly, fluoroscopy I find actually really helps understand anatomy because you're doing EUS and you're also injecting contrast, and then things all of a sudden light up and make sense to you. So it's a backwards way of learning. You can't teach trainees by starting with interventional EUS, but as you do more and more interventional EUS as time goes on, then that further enhances your education. So in conclusion, I'd say it's important to understand the basics of ultrasonography overall, to understand EUS. We need to know our equipment like any other procedure. We need to know our EUS scopes, our EUS machines, what features we have, what limitations we have. Understanding artifacts, that's important. I didn't really go into it, but that could be something to go over in the future. And then the anatomy, it's really a matter of repetition and then understanding the basics of anatomy and just sort of going back and forth and really leaning on your mentors, your senior faculty who you have great ones in Pakistan who can teach you how to sort of enhance your skills. So with that, I'll stop and I'll be happy to take any questions if there are any.
Thank you, Mustafa. Thank you very much for a very nice and elaborate presentation. One other aspect which I'm sure everyone will like to know, because most of the ones keen learner, just a few days back I came across a comment that unless you, previously just we thought that unless you know ERCP, you're not a complete gastroenterologist. Now they think that if you don't know how to do EUS, you're not a complete gastroenterologist. So two things that I should like you to highlight. How correct this method is, number one, and number two, what are the learning curves for EUS? Is it for everyone, or
yeah, okay, go ahead. Sorry.
You need to go through a certain training period? How many procedures minimum are needed before you can say that, okay, fine, now I'm good enough to do that? And then I understand that Lawrence is going to talk about learning opportunities in EUS in the coming days, but just a brief highlight how important it is to have a proper mentorship in EUS.
Yeah, I apologize. I didn't really go into it too much. I think so. In terms of completeness, my philosophy is a bit different. I think we're all complete in our own way, and then we decide to think to ourselves, well, I'm not complete in this respect, so I need to do more. So as a gastroenterologist, does every gastroenterologist need to know EUS and ERCP? Of course not. It's similar to, I am a gastroenterologist. I do primarily, EUS, ERCP therapeutic procedures. If I intentionally stay quiet when it comes to IBD topics, hepatology, it doesn't mean I don't know some of it, but I by any means don't know a lot of it. And so I think we have to find comfort knowing that it's better to focus and be very focused on things that you know that are your strengths and go with those and not worry about things that are not your strengths, which brings you to the point, is it for everyone? And the answer is no. ERCP and EUS are not for everyone. EUS certainly can be learned to a degree, ERCP can be learned, but just like GI is not for everyone, similarly EUS, ERCP is not. And I think it's okay to try, and if it doesn't work out, not do it. But to not jeopardize patients' health because you feel that I have to do this. It's similar to ERCP. If you're not successful cannulating a lot of the time, either you just don't know all the principles or you're just not cut out for it. And I think with EUS too, it shouldn't be something I will go to a weekend course and I will start doing it. I think, unfortunately, that has been encouraged even in the US and Canada. And I strongly feel that it should be training, sustained training. Having said that, I think we have to look at the reality on the ground and say, how can we best optimize this? And I think some of if anybody was to look at, and I don't say this because you have invited me or you guys are the hosts, but the way what you have done and Dr. Saad Niaz has done is to be consistent and persistent in your quest to get this knowledge and experience. And you've been to centers, you have practiced, you have had other people come in and have them show you, and you've been very gracious and kind in terms of allowing juniors to you to come to Pakistan, to the centers and teach. And I think now Pakistan's at a point where you're obviously carrying that mantle forward and allowing trainees to learn. And I think it has to be like this. It has to be people who are experienced teaching it and trainees spending hours learning it and months learning it. This is not something you learn over a matter of course of time. The number of procedures is always tricky for me because there are some sort of vague numbers, 200 cases, 75 FNAs, etc. It doesn't matter, to be honest. I have, over the years of my training, I have had fellows who have done basically a whole year and have struggled with one aspect. And then there are those who have just done 3 months and they're quickly catching on to various aspects. So it's really a matter of achieving competency based on the task at hand. Can this provider identify the pancreatic duct all the way from the papilla to the tail of the pancreas? Can this provider sample a pancreatic mass? What is their diagnostic yield for a mass? Is it like for a pancreatic mass that's 2 centimeters? That's very different compared to a 5 millimeter lymph node. You know, that's going to be more challenging. So I think getting to those levels of competency that we should be roughly, I would say FNA yield should be 90% plus, and diagnostic wise, basically high 90s in terms of being able to visualize pancreas, bile duct, etc. Unless of course there's some altered anatomy. So I hope that kind of answers your question, but it's not something that's for, in short, not for everybody. It's okay if you don't do it. And thirdly, it does require a lot of sustained practice, and it's the right thing to do it for the patients.
Okay, there's a question from Master Nadeem Tehami. What is the best scope position in D2? Long scope position or short scope position, especially while teaching training in a fellow, as scope falls back in the stomach if trainees' movements are not small. And secondly, any tips or tricks of interpreting pylorus D1 with echo endoscope? Is it same setting sun approach like ERCP?
So, you know, I think part of it is the type of scope you have. What I've noticed is, and I have had the sort of, just because of my work situation, fortune of working with both the two main brands, which are Pentax and Olympus, that the Pentax scope tends to want to fall out of D2 into D1 and stomach quicker than the Olympus. I personally like to do both views. My personal approach is I start in the bulb, I do my bulb evaluation, and then I reduce to the second. A full exam would require you to do both. If you had to say, well, what's the best? It depends on what you're doing it for. Because if you're looking for a stone in the bile duct, perhaps you can do the entire thing from the bulb. You can start from the top, go to the bottom, and vice versa. So I would say some ways to stabilize the scope in the second position portion would be to put the balloon up a bit, big wheel towards you, or flexing into the duodenal wall. And I didn't show this in the movements, but a lot of the movement there can also be wrist as opposed to the entire scope, because sometimes wrist will keep your scope stable, whereas if you counterclockwise your scope, you'll fall back. So that's another strategy. So I would say, depending on what you're looking at, you have to potentially do both, but sometimes you can get away with just bulb. And the second one was intubating pylorus D1 with the echo endoscope. You know, I don't make a big deal of it personally. I essentially look for it, and similar to the ERCP scope, I do lift the big wheel up a bit and then advance. So similar to the sunsetting position. Once you're there, though, that's the tricky part, because with the Pentax, that's a longer, stiffer shaft, and you have to be very careful there. I generally tend to like to use my big wheel up and then small wheel to the right, and maneuver the tip with the scope dials, and then gently advance the scope. And definitely with the Pentax, I will put up the balloon. With Olympus, oftentimes you can do it similar to the ERCP scope, somewhat blind. You can just do the reduction without necessarily being that finessed.
Okay, we can see Nadeem in the audience. Similarly, Master Khalid Hassan is also there. Can we have quick comments from Nadeem and then Khalid? Nadeem, please.
First, Tayyib, thank you very much. And Dr. Arain, thank you very much for an excellent talk. I had two questions and I've asked them, and I think Dr. Arain have answered them. So I'm grateful and thank you.
Khalid, are
Can
you
you
there?
hear me?
Yes, we can hear you, but we cannot see you. Let me,
I am.
let me introduce Khalid, that he has been the one who has been teaching us ever since we started US. I, as well as Sadhnyas. Sadhnyas is, I think he has gone somewhere. I don't see him in the list at the moment. He must have some engagement. He left in between. But Khalid is the one who has taught us US. He has groomed us in the US, and he has I should say कि जैसे बच्चों को उंगली के साथ पकड़ के लेके चलते हैं, he has taught us all the way. And similarly, Mustafa has been teaching us, and all other people, all other friends who are working in various parts of the world, they have been contributing, they have been helping us in developing the US services in Pakistan. Khalid, आप कुछ कहना चाहें?
And thank you so much, Gaspai, for these kind words. Mustafa, that was a wonderful presentation, and I think you answered questions quite nicely. The only thing, one thing I would add is like whenever, especially you are in D2, as answer to the last question, when you are in D2, please do not lock the wheels of the EUS scope. That is very, very important. As soon as you lock the wheels, it makes it really stiff. And we are used to that with the ERCP scope. With the EUS scope, that is a very, very stiff scope, and don't do that. Other thing is D2 exam. For some people, it's quite tricky, and sometimes it's hard to learn. But it can be made very simple. Just try to put the scope in like a ERCP scope. You can take a look at the ampulla, and either endoscopically, and whenever you do that, put the transducer on top of that. You are just remember that you are never on it when you do that. You are always distal to that. So you have to pull the scope a little bit back to really get the ampullary view. And I think as we go along, there are going to be a lot of people giving talks. I think that would be a totally separate talk on pancreas examination. So don't want to take too much time or thrill out of that. But it is important that just do a small movements, have a control of the scope, have the scope straight, and repetition, repetition, repetition. That's how you are going to learn EUS. So I think I'll stop there because I'm at Disney right now while watching Mustafa and you guys. So
Great, Khalid, excellent, wonderful seeing you.
Thank you.
It's for me to thank Mustafa because it was early in the morning. It was 6 in the morning at his first place, and I'm really thankful to him for waking up early and give such a nice presentation to the audience in Pakistan. I'm really thankful to you on behalf of Pakistan Society of Gastroenterology and Endoscopic Ultrasound Group of Asia. Similarly, University of Health Sciences, College of Physicians and Surgeons, Pakistan, and King Edward Medical University and Dow University of Health Sciences. I'm really thankful to the participants for sparing their time, and similarly, I'm thankful to Junaid for helping me in organizing this webinar, and at the same time, my thanks to Said and Wilson Pharmaceutical for giving us a platform for delivering these webinar sessions. Which are going to be a weekly affair at 6 in the evening. Next time, we're going to talk about ERCP accessories. And with these words, goodbye and assalamu alaikum to all of you. And thank you once again, Mustafa. In case you want to say something.
Just thank you very much for the opportunity, and it's a pleasure to be part of this. And mashallah, everybody's doing great work. So thank you once again.
Thank you. Assalamu alaikum. Khudafis.
Perfect.
Thank you so much.